Welcome everyone to this class on antimicrobial resistance. Now, this is a huge topic in general. So what I've tried to do is we'll discuss it as a case-based approach rather than, going into details of mechanisms of resistance because a lot of times it is very complicated to understand which mechanism is at play. But what eventually matters is how you choose the antibiotic therapy for your patients. Now, why we are doing this case-based approach on antimicrobial resistance is because we recently had the World Antimicrobial Awareness Week. We are slightly late in organizing this, but it's better late than never. So 18th to 24th November every year is celebrated as the World Antimicrobial Awareness Week. And with this seminar, especially the audience being young physicians or people who are already practicing, it is very important that we, put this message across that it is everyone's responsibility to use antibiotics responsibly. Now, if you just look at the basic data, which is the most recent data from this Lancet article, you'll be surprised to see that approximately 1.27 million deaths were directly attributable to antibiotic resistance. Now, 1.27 million deaths is a very big number, and it could still be an underestimation, uh, given the numbers of 4.95 millions that they think are associated with antimicrobial resistance. So, approximately 15 lakh, 13 lakh people dying just because of resistance, and possibly 50 lakh people dying because of antimicrobial resistance. And if you look at the region wise performance, I mean, South Asia isn't faring much better than the Western or African counterparts, where the mortality rates due to antimicrobial resistance continue to be high. And if you look at the major organisms that are responsible for these deaths, it's the common ones that everybody who's practicing medicine, as in like from medical fields or surgical fields, you keep coming across E. coli, Klebsiella, Staphylococcus, Acinetobacter, especially in hospital acquired infections, in high burden settings or ICU settings. And these are the major organisms that are responsible for deaths in these patients. And if we just look at the prevalence of resistance, it's alarmingly high. So if you look at the prevalence of ESBL E. coli or the extended spectrum beta lactamase producing E. coli, India is between the 70 to 80% mark, which is very high, which makes a lot of antibiotics useless as our empirical choice in patients. And if you look at carbapenem resistant Klebsiella, again, India is amongst the leaders, something not to be very proud of. India's between 50 to 60% carbapenem resistant Klebsiella. Frankly, in practice, we see it even more than 50 to 60% mark. But again, it depends on which place you're practicing. If you're practicing at a tertiary care center, referral centers, you're likely to see more resistant organisms than the primary or secondary centers. Again, Acinetobacter, more than 80% resistance to carbapenems. And if we look at the MRSA rates also, it is between 50 to 60%. So this is just to highlight the magnitude of the problem because, with time, we are having even lesser and lesser number of options to treat our patients. Now, this was a brief introduction. Some of the data might be useful for you in general, but it's very important to know that the problem is not in the future, the problem is in the present time. And is it really making a difference? Yes. Again, a recent paper where we see that if you look at the combined effect size, the odds ratio is around 1.8. So almost two times. So a person with a resistant infection is two times more likely to, die because of the infection compared to a person who's not having a resistant infection. And if you look at the global estimates of mortality, it is expected that there will be 10 million deaths by 2050, costing approximately $66 trillion to the global economy. For comparison, the economy of India at this point is close to $4 trillion. So you can imagine the amount of money that this threat or this menace is going to cost everyone. And even if you look at hospital readmission rates, patients who are treated for resistant drug resistant infections are even more likely to get readmitted. So Now that we have gone through a basic introduction on the topic, let's discuss our first case scenario. Now, these cases are real life cases that you see again on and off, and it's a real problem that you have to decide on the choice of antibiotic while you're waiting for culture results, or even once you have the culture results, how do you optimize the antibiotic choices? So this is a 35-year-old non-pregnant female with history of recurrent UTIs and who now presents to the emergency with lower urinary tract symptoms, fever, decreased urine output, and she has history of taking multiple courses of antibiotics as an outpatient, which includes nitrofurantoin, levofloxacin, and cefuroxime. Now, at presentation, the patient is drowsy, the blood pressure is on the lower side, she's tachycardic, and the CV angle is tender. Now, the question is, what do you do? Now, feel free to, keep putting your answers in the chat box. We'll not be dealing with individual answers, but you can, of course, check what you said is probably in line with the best medical practice. Now, first option is supportive management, no antibiotics till cultures are back. Now, this is, of course, not the right option because the patient is sick, right? The patient is nearly hypotensive, tachycardic, and you don't want to wait because with delay in initiation of antibiotics, you are likely to have poor outcomes. Again, the other options are to choose between ceftriaxone, piptazo, and meropenem. Now, I've just showed you that the prevalence of, drug-resistant infections are increasing. Plus, this patient has risk, exposure to antibiotics, history of recurrent UTIs. So, in these cases, you would actually start with a broader spectrum antibiotic, and then eventually, once the culture results are back, you can always de-escalate. Now, remember, as an antibiotic steward or somebody who wants to prescribe rationally, the the heroism is not in giving ceftriaxone to a patient. The correct thing to do is you find the right appropriate antibiotic for the right syndrome and the presentation. So in this patient, since the patient has risk factors for drug resistant infection, the patient is on the sicker side, what you'll do is you'll probably start with a higher end antibiotics, maybe piptazo, maybe meropenem, but not ceftriaxone. Now, talking about covering MDROs, right? When do you think of MDROs and when do you think of broad spectrum antibiotics to begin with? Now, if there's a history of previous infection with MDR organisms, hospitalization, antibiotic exposure, indwelling devices, known colonization status, presence of septic shock, hospital-acquired infections, breakthrough gram-negative bacteremia. So, for example, a patient got admitted, has E. coli sepsis, sensitive to ceftriaxone. Patient is doing well, but day 5 or day 7 again starts having new fever, new worsening. At that time, you would empirically escalate to cover multi-drug resistant organisms. Again, comorbidities, immunocompromised status indirectly relates to previous hospitalization, devices, etc. So in those cases also, you might as well think of multi-resistant organisms. Now, when do you think of combination therapy for suspected gram-negative infections? Now, empirically, in cases of immunocompromised patients, patients with septic shock, and hospital-acquired infections in settings with high prevalence of drug-resistant organisms. Now, for example, immunocompromised patients. Now, all guidelines recommend that if the patient is sick, and what you do is you first start with a combination therapy to ensure that Pseudomonas is covered. Now, what this means is till you have culture results or till you know what is the cause of the presentation, you might be justified in starting two antibiotics, thinking that if antibiotic A is covering 60% or 70% of these strains, antibiotic B will probably cover remaining 20-30% of these strains. But as soon as you have your culture sensitivities back, almost always we'll switch to single agent. Directed combination therapy is given only in very select cases, especially when the efficacy is not known. For example, Acinetobacter infections. Now, you would want to combine, a sulbactam-based antibiotic with either polymyxin or tigecycline rather than giving any of these treatments alone. Now, coming back to our case. So we have this culture updated, and what we have seen is blood and urine cultures both are positive for E. coli. And what we notice here is that it is ceftriaxone resistant. It is sensitive to amoxiclav, sensitive to cefoperazone sulbactam and piptazo, and it is also sensitive to carbapenems. Now the question is, what do you start? Maybe you had started piptazo initially. Do you want to switch? If you started meropenem, do you want to continue meropenem or switch to something else? And once the patient is stable, do you want to de-escalate to an oral treatment, and what should be that oral treatment? Now, before we discuss this case, let's quickly revise the mechanisms of resistance in beta-lactam antibiotics. Now, there are multiple types of beta-lactamases. It could be penicillinase, cephalosporinase, but what we are mostly interested in is ESBLs, AMPCs, and carbapenemases. Now, the most basic way of identifying if a strain is an ESBL producing strain or an AMPC producing strain is that you look at ceftriaxone and cefepime, or ceftriaxone, cefepime, and BL-BLI combination like piptazo or cefoperazone sulbactam. So if the bacteria is resistant to ceftriaxone, if it is resistant to BL-BLI combination, but sensitive to cefepime, it is the AMPC producer. If it is sensitive to BL-BLI combination, resistant to ceftriaxone, and maybe resistant or sensitive to cefepime, it is an ESBL producer. I'll summarize this again. So this is the chart or table by which you can say if it's an ESBL producer, it will be inhibited by the BL-BLI combination, that is piperacillin tazobactam or cefoperazone sulbactam. Both these strains are going to be ceftriaxone resistant, but cefepime will be sensitive in AMPC producer. Now, why is this important? It is important because if it's an AMPC producer, the treatment of choice is carbapenems. If it is an inducible AMPC producer, even then the treatment of choice is carbapenems. Now, going back to this table. So this is a very famous Ambler classification for beta-lactamase production. Now, how do we make sense of this is the question. Now, first of all, take the odd one out, which is class B. So you take out class B, which is metallo-beta-lactamase. Now, these are the most notorious types of beta-lactamases, and they hydrolyze carbapenems. Now, there are very few antibiotic choices when we are dealing with metallo-beta-lactamases. Now we are left with class A, B, and class A, C, and D. Class C, we have already spoken about. It is the AMPC producer. Now we have class A and class D. Now class A and D, both the classes have ESBL producers as well as carbapenemase producers. Again, it might be confusing, but as and when we go forward with examples, you will understand the relevance of all this classification. So quickly moving forward, this is again a list of inducible AMPC producers. So if you see these organisms, in those cases, even if it is BL-BLI sensitive, what you will choose is carbapenems because these organisms can produce AMPC and become resistant to BL-BLI combination. So this is important to note. So coming back to the culture report. So here you see that the patient's isolate is resistant to ceftriaxone and it is BL-BLI sensitive. So this becomes a ESBL strain. Had this been BL-BLI resistant and carbapenem sensitive, it would have been an AMPC producer, right? Now the question is, if this is BL-BLI sensitive, then can we give this patient a BL-BLI combination like piptazo or cefoperazone sulbactam? Now I want to introduce you to another concept where we want to look at the MICs as well as breakpoints. Now, if you look at the MIC of cefoperazone sulbactam over here, it is 16. And if you look at the susceptibility breakpoint, what we want is less than equal to 16. So it is on the brink of sensitive turning into intermediate. So if we take a ratio of breakpoint to MIC, it is going to be 1. Whereas if we look at imipenem or meropenem, here if we take a ratio of the breakpoint and MIC, the ratio is going to be 4. So what I mean to say is, generally, if you have multiple sensitive antibiotics, then what you can do is you can look at the breakpoint is to MIC ratio. Now, there is no fixed rule that the ratio should be more than 4 or more than 8. The general rule is higher the ratio, more better the antibiotic. Like it would work even in lower doses. That's the whole concept. Now, that is point number one. So you look at the breakpoint is to MIC ratio. So always ask your lab to give you breakpoints, because getting MICs alone may not be helpful, right? Because based on this, even cefoperazone sulbactam is sensitive, imipenem is also sensitive. But when you look at the breakpoints, you know that the breakpoint is to MIC ratio is 1 for cefoperazone sulbactam, whereas 4 for imipenem and meropenem. So in this case, imipenem or meropenem becomes a better choice, even though cefoperazone sulbactam is also sensitive. Now, this is based on this particular report. Now, for example, this patient was sick and the cefoperazone sulbactam breakpoint to MIC ratio was also 4, and carbapenem breakpoint to MIC ratio was also 4. In that case, could you have gone with cefoperazone sulbactam or maybe piperacillin tazobactam? The answer is again no. Why? Because the most recent paper, the Merino trial, that showed that in ESBL producing infections, especially if the patient is sick, BL-BLI combinations are not as good as carbapenems. So if the patient is sick, even if it's a BL-BLI sensitive strain, you would probably want to keep the patient on a carbapenem-based therapy, right? So two concepts that I've introduced. First, if it's an ESBL producer sick patient, your treatment of choice becomes carbapenem. If not, and if you want to choose between different antibiotics in a sensitive strain, what you can look at is breakpoint is to MIC ratio. Higher the breakpoint is to MIC ratio, better the chances for that antibiotic to be effective. So that we have talked about treatment options. So in this particular patient, my choice of treatment would be carbapenem. It would have been carbapenem at the time of admission as well as after the culture reports became available. Now comes the question of oral de-escalation. So you're given the patient 5 days of IV antibiotics. Patient has now become stable, taking orally, no issues with absorption. You think that the patient can take oral medication. So what is going to be your choice in this case? Now we see that ciprofloxacin is resistant. So fluoroquinolones are out. The other oral option is amoxiclav. But like I said, amoxiclav is not going to be a good choice in this patient. The next oral option that I can see over here is nitrofurantoin. Now, again, nitrofurantoin is not going to be a good choice because this was a pyelonephritis with sepsis. So nitrofurantoin is a good choice only for cystitis, but not for pyelonephritis or bacteremic patients. And the last option that I see here is Septra or trimethoprim sulfamethoxazole, which is a good option. So say this patient improved well on meropenem, you gave it for 5 days, patient is doing fine, patient wants to go home, you can switch this patient to cotrimoxazole to complete the remaining duration of treatment. So I hope with this case scenario, it was pretty clear as to how we approach a case of a culture positive report based on various susceptibilities. Next, same patient, say this was the culture report. Now, in this case, ceftriaxone is sensitive, right? So it's not an ESBL producer. In fact, it's a pan-sensitive strain. All antibiotics that were checked is sensitive. Now, in this case, again, if I had started meropenem, I would switch back to ceftriaxone because ceftriaxone is going to be as good as piperacillin tazobactam. So we can go with the narrowest spectrum antibiotic in this case. And again, if we want to switch to oral, since ciprofloxacin is sensitive, now between cotrimoxazole and ciprofloxacin, I would go with a fluoroquinolone because of better pharmacokinetics with fluoroquinolone. So instead of ciprofloxacin, you can easily go with levofloxacin once daily when you want to de-escalate. As long as the patient is sick, you think the patient is not going to absorb the antibiotics, you can go with IV ceftriaxone or even IV levofloxacin in those cases. So that is how we decide based on culture reports. Now, coming to case scenario 2. So that was first case, urosepsis, UTI. First isolate was ASBL E. coli. The second isolate was a pan-sensitive E. coli. And in both the cases, now we know how to manage those infections. Case scenario 2. So there's a 25-year-old male with small bowel gangrene and perforation. So very important, that's a perforated bowel. Undergoes emergency small bowel resection and anastomosis. Preoperative and intraoperative peritoneal, preoperative blood and intraoperative peritoneal fluids have been sent for culture. And the patient was empirically put on meropenem because of the intra-abdominal sepsis. Now, blood and fluid cultures have returned positive, and the patient is continuing to spike fever on meropenem. So the obvious reason probably here is if it's an Enterobacteriaceae, it is a carbapenem resistant, or maybe the infection is because of some other infection. Infection is because of some other organism, because it's a bowel perforation. It could be candidemia, it could be enterococcal infection. But for simplicity's sake, this case is going to be a carbapenem resistant Klebsiella pneumoniae infection. Now, if we look at the sensitivity pattern, what we notice here is that the colistin MICs are very low, it's less than 0.5, and tigecycline is sensitive. Now, the important point here is that the blood culture is also positive. Now, how do you approach the situation? This is the sensitivity we have. What would you use as your antibiotic of choice? Or is there something else that you would want the lab to perform? I would want to see some answers on the chat for this case. So are you going to do this thing, like give the patient colistin or give the patient tigecycline? So tigecycline MIC is 0.5 and the breakpoint is 4. And for colistin, carbapenems are all resistant. Every other antibiotic is resistant. So somebody says colistin tigecycline won't work. So what do you do next? Do you want the lab to perform any additional, sensitivities? Right. So somebody has asked for synergy testing for ceftazidime, avibactam, and astronam. So we see that individually, astronam and ceftazidime, avibactam are resistant. But rightly said, we would want to know the ceftazidime, avibactam, astronam synergy test. Now, why do we want that, and why can't we go ahead with colistin or tigecycline? Why not tigecycline? Is because there is bacteremia, right? So for bacteremia, tigecycline is not the best drug. Second, colistin or polymyxin B, in general, as per the most recent guidelines, polymyxins have fallen out of favor. So most guidelines or the most recent IDSA guidelines do not prefer polymyxin B as the first choice of treatment unless you are not left with anything else. So what we did is we did the synergy test for ceftazidime, avibactam, and astronam, and it turned out to be positive. So what we are going to do in this patient is we are going to give this combination. Important point about this combination is both the antibiotics have to be given simultaneously. So if the patient has no renal dysfunction, we give 2.5 grams of ceftazidime, avibactam every 8 hours with 2 grams of astronam every 8 hours. And we instruct the nursing staff to give both the injections at the same time so that they reach the same concentration as in the concentration in the blood at the same time. Now, same situation, same culture report, but look at some other scenarios. So if it was a case of a ventilator-associated pneumonia with same susceptibilities, we could have still gone with ceftazidime, avibactam, astronam combination. But if it was only an intra-abdominal infection or maybe only a bone and joint infection without bacteremia, in those cases, we could have gone with tigecycline alone because tigecycline has very good intra-abdominal concentration as well as it is very good for skin soft tissue and even bone musculoskeletal tissue. If it was pyelonephritis, we would have again gone with ceftazidime, avibactam, astronam. Now, for example, if this isolate was E. coli and the synergy test was negative, now this is not uncommon. For E. coli, for approximately 20 to 30% of the isolates, the synergy test is negative. And say this patient had pyelonephritis with the same set of antibiotics, what would you have done at that time? Would you give polymyxin B or would you give colistin in a case of pyelonephritis? So what we'll do is we'll go with colistin instead of polymyxin B. Now, poly B and colistin are interchangeable for everything in terms of susceptibility. Polymyxin B has a much better pharmacokinetics, less nephrotoxic, does not require renal modification, right? So, except for pyelonephritis, that is UTI, the treatment of choice is polymyxin B. But in case of pyelonephritis or urinary tract infections, what we prefer is colistin. Again, you may or may not give it in combination with tigecycline, but for pyelonephritis alone, tigecycline is not a great choice. Next is if this isolate was a carbapenem resistant pseudomonas with the same susceptibility profile, and the lab had reported tigecycline. But the problem is we could not have used tigecycline for carbapenem resistant pseudomonas because of intrinsic resistance. So even if the lab reports it by mistake, which it shouldn't, tigecycline cannot be used for Pseudomonas aeruginosa. And if this was a carbapenem resistant Acinetobacter infection, in that case, ceftazidime avibactam astronam wouldn't have worked. Then we would have been left with colistin based regimen. I'll be talking about a case of carbapenem resistant Acinetobacter infection later. But what we need to keep in mind is tigecycline does not work for Pseudomonas and ceftazidime avibactam astronam combination does not work for Acinetobacter. Next important point is to add anaerobic cover when appropriate. Now, why have I mentioned this? It's because, say, in our case, it's a perforated bowel with a secondary bacterial peritonitis. So do you really think that it is going to be a monomicrobial infection? And if polymicrobial, even if Klebsiella pneumoniae is the predominant organism, you're likely to miss anaerobic infections, correct? Because the gut is full of anaerobes. Ceftazidime avibactam astronam in general does not have a good anaerobic cover. So if you're suspecting a perforated bowel, intra-abdominal abscess, ongoing biliary leak, etc., even if you're growing Klebsiella pneumoniae, I would, prefer adding an anaerobic cover, especially if I'm using ceftazidime avibactam astronam. But if I was using tigecycline, it has excellent anaerobic cover. In those cases, I wouldn't add additional metronidazole. So these are some important, finer points. I mean, you will get to learn this with practice as and when you keep seeing these patients. But these are the finer points that make a lot of difference in patient management eventually. Now, just briefly, I'll talk about the synergy test. It is done by various methods. This is one of the standard methods. So I'll just walk you through this photo, this diagram. The first one is a E-strip of ceftazidime avibactam. Here you see that there is a zone of inhibition around the E-strip, which shows there is some sensitivity to ceftazidime avibactam. If you look at number B, what you see is there's only an inverted D-shaped zone of inhibition between the astronome disc and the ceftazidime avibactam strip. This shows that individually the bacteria is resistant to both the antibiotics, but when both the antibiotics are present in this area, there is a zone of inhibition. So this is resistant to ceftazidime avibactam, resistant to astronome, but sensitive to the combination, right? If you look at figure number C, in this what we see is it is sensitive to ceftazidime avibactam and it is potentiated by astronome, but it is individually resistant to astronome. There is no zone of inhibition on the other side of astronome disc. And the reverse is true for last photo, where it is resistant to ceftazidime avibactam alone, but there is a zone of inhibition around astronome, and there is a potentiation where there's an effect of both the antibiotics. So whenever either of B, C, and D is positive, we say that there is synergy between ceftazidime avibactam and astronome. Now, coming back to our case. So it was a carbapenem resistant infection, Enterobacteriaceae, and it is sensitive only to colistin, tigecycline, and we check the synergy test, which is sensitive. So based on the IDSA recommendation, the preferred regimen here is going to be ceftazidime avibactam astronam. Cefiderocol is another antibiotic which works through a different mechanism. It is not available in our country, but it is being readily used in America, US, for carbapenem resistant infection. Now, if you look at the top and bottom of this table, where the mechanism of resistance is identified to be KPC or OXA48, you can actually use other antibiotics because ceftazidime avibactam has activity against KPC and OXA48. So if it is KPC or OXA48, only ceftazidime avibactam alone is enough. If it is KPC, then newer antibiotic combinations like meropenem vaborbactam and imipenem relebactam can also be used. In our setting, we mostly see metallo-beta-lactamase. So most of the times, 9 out of 10 times, what we end up using is ceftazidime avibactam astronam. Rarely, if we see an OXA48 on BioFire, I'll be showing you an example. Rarely, if we see OXA48 present carbapenem resistant, what we do is we only give ceftazidime avibactam. Now, coming to case scenario 3. So we have discussed pan-sensitive E. coli, ESBL E. coli, we have discussed carbapenem-resistant Enterobacteriaceae. Now coming to our third case, this is again, all cases are real cases. 26-year-old male underwent splenectomy 3 months ago at an outside hospital, and he has received his post-splenectomy vaccination. Now presents with fever, left upper quadrant pain for 5 days, and on evaluation, we see a large 5 into 4 into 4 centimeter collection in the splenic fossa region. So we tap it, 15 ml of pus is removed, and it is sent for culture. And to our misfortune, we have this pus culture report. It may not be very clear. I'll just read it out. So it's growing Pseudomonas aeruginosa, and every listed antibiotic is resistant. So we have very high MIC values for all the antibiotics, and you will notice that there is colistin reported as intermediate with an MIC of 2, but we asked the lab to confirm it with broth microdilution method, and it was updated to be 4. So the MICs of colistin were even higher. And the synergy test between ceftazidime avibactam astronam is negative. So now we are stuck. It's a pan-drug resistant Pseudomonas infection. Any bright ideas? What could you do in this case? Pan-drug resistant Pseudomonas. Okay, so let's just discuss what do the recommendations say about managing drug-resistant or difficult to treat resistant Pseudomonas infection. So the 2023 IDSA guidelines have divided into preferred and alternative treatment regimens. Now, till we were talking about Enterobacteriaceae, major mechanism of resistance are usually beta-lactamase production, be it AMPC, be it metallo-beta-lactamases. But for Pseudomonas, even efflux pumps become very important. So in this case, what the guidelines say that you have 3 options. First is ceftolozane tazobactam, ceftazidime avibactam, and imipenem relebactam. Now, imipenem relebactam is not available in our setting. So we are left with ceftolozane tazobactam and ceftazidime avibactam. But the problem is these cannot be used empirically unless the culture sensitivity report has documented them to be sensitive, right? So in our case, ceftazidime avibactam was resistant. We had asked the lab for ceftolozane tazobactam also. It turned out to be resistant. And the alternative mentioned in the guidelines is cefiderocol. They've clearly moved away from polymyxins. In our case, anyway, polymyxins could not have been used because it was the MIC was 4. So what next? So we were completely stuck with this case. What could have been done? So then, we contacted a pharmaceutical company which is developing a new molecule called cefepime zidebactam. Now we were able to procure cefepime zidebactam for this patient. It's a beta. So zidebactam is not only a beta lactamase inhibitor, but it is also a beta lactam enhancer. So in addition to inhibiting the beta-lactamase activity, it also helps the beta-lactam, which is cefepime, to have a better activity. And fortunately, the isolate was sensitive to cefepime zidibactam, and patient has shown very good response so far with this treatment. But what I'm trying to highlight here is, just imagine a young 26-year-old male with a pan drug resistant pseudomonas with no effective treatment. The patient comes to us in the OPD and asks us, like, what do we do now? So it is like diagnosing terminal malignancy, right? You know the disease, but you don't have the treatment. Like you just wait and watch, you keep trying different combinations, but if it's resistant, it's probably not going to work. So it becomes even more important to be, very careful about your antibiotic choices in general. Now, so again, we have just discussed a carbapenem resistant Pseudomonas aeruginosa, or a difficult to treat resistant Pseudomonas aeruginosa. Coming to our next case, it's a 60-year-old male, hypertensive diabetic COPD, a very usual ICU admission in any of the hospitals. Initial sputum culture shows Klebsiella pneumoniae, which is sensitive to carbapenems, probably an ESBL, probably an AMC producer. And on treatment, the patient has significant clinical improvement until day 7. And on day 7, he has a new onset fever with increased oxygen requirement. Chest X-ray shows new right-sided inhomogeneous opacities, this progressive respiratory failure, and he gets intubated. So it's like looking like a hospital-acquired pneumonia in a patient with all the comorbidities listed. Now we send an ET aspirate, and the gram stain is showing a gram-negative coccobacilli. So whenever you're seeing a gram-negative coccobacilli, what should it ring in your mind? It should ring Acinetobacter. So when we saw the culture report, it says there is Acinetobacter baumannii, which is growing. It is resistant to cephalosporin sulbactam, sensitive to tigecycline. The MIC is 0.5. Minocycline is intermediate, MIC is 8. And colistin is intermediate, MIC is 1. Now, quickly, I'll talk about colistin sensitivity interpretation, right? So you've seen that I have not mentioned colistin sensitive. Why is that? Because recent guidelines, CLSI guidelines, have removed the sensitivity or susceptibility reporting for colistin. So it is either reported as intermediate or it is reported as resistant. It is reported as intermediate until an MIC of 2. Above the MIC of 2, it is reported as resistant. So even if colistin MIC is 0.5, it will be reported as intermediate. At an MIC of 2 also, it is going to be reported as intermediate. But the chance of colistin working is better if the MIC is less than equal to 0.5. If the MIC is 1 or more than 1, then the chance of treatment failure is higher. Okay, so that is another important point. Now, the question is, the patient has a hospital-acquired pneumonia. You have the sensitivity pattern. So what are you going to do? Are you just going to give a combination of colistin and tigecycline, or is there something else that you could do in this patient? Again, I'll just wait briefly for some answers. Any other antibiotic that you would want to combine, or would you just give colistin plus tigecycline? Okay, somebody says ampicillin sulbactam, somebody says colistin plus minocycline, ampicillin and high dose mino-T. Great. So we have good answers over here. So if we look at, again, we'll go back to the most recent IDSA guidelines on managing crab infections or carbapenem resistant Acinetobacter infection. So first point is we use a combination therapy with more than equal to 2 active agents. So there has to be at least 2 active agents. Now, the first point in the blue box is you use high dose ampicillin sulbactam regardless of whether susceptibility has been demonstrated. So in our case, we saw that cefoperazone sulbactam was resistant. Now, the whole point of using ampicillin sulbactam is basically for the purpose of using sulbactam, right? So if you have sulbactam available independently, you can just straight away add 3 grams TID of sulbactam for managing severe Acinetobacter infections. But you have to give it in combination with one of the other agents, right? One or more than one of the other agents. So it could be poly B, it could be tetracyclines, or it could be cefiderocol. Cefiderocol again is not available in our setting. So in this patient, if the patient is really sick, what I would do is I would give poly B with a high dose minocycline, and I would add sulbactam to this patient. If sulbactam is not available, either we give a high dose ampicillin sulbactam or we give high dose cefoperazone sulbactam. So that is what we can do in crab infections. But the question is dosing of tetracyclines. Now, regarding dosing of tetracyclines, what is mentioned is you use higher doses. So if you're using minocycline, you use 200 milligrams 12 hourly, or if you're using tigecycline, you use 100 milligrams 12 hourly. Normal tigecycline dosing is 100 milligrams loading followed by 50 milligrams 12 hourly. But for difficult to treat infections or crab infections, you would use double dose. Now, all of these things are very easy to read and, just maybe prescribe, but you have to remember that these are very expensive treatments. So if you're giving somebody poly B with, IV minocycline or high dose tigecycline in combination with, say, sulbactam or cefoperazone sulbactam, you're probably putting back the patient by, maybe 30,000 rupees or 40,000 rupees every day. And the patient would obviously be having so many other issues. So again, of course, we have to manage these infections very well, but our primary goal is to prevent hospital-acquired infections. Crab pneumonias don't come from community, right? Crab pneumonias mostly are from the hospital setting. CRE, CRP, you can still get from community, right? Given the high use of antibiotics and higher antimicrobial resistance in general. But crab and all, I mean, it is everybody's responsibility, that there's strict infection control practices, hand hygiene, everything is maintained so that your patient does not, recover from one disease and then dies of some other disease, and that too a very expensive one, right? So that is something I wanted to highlight. Again, something that we really want to look forward to is this new drug, which is sulbactam durlobactam. It could again be important from your exams perspective, which was recently shown to be very effective for Acinetobacter infections. So 2 grams Q6 with or without combinations with carbapenems was shown to be very effective for Acinetobacter infections. So remember this sulbactam durlobactam. Now, coming to another case scenario, most people who are working in tertiary care or even, medical colleges would have come across a biofire. Now, in my experience, in my limited experience, I should say, biofire reports at times create a lot of confusion. Patient is doing fine, patient is getting better. You do a biofire, it shows positive. Patient has completely improved on, say, ceftriaxone or piptazo, and then you do a biofire and it shows the NDM present. What do you do? So that's what, like, there could be scenarios where there is a discordance between the clinical and microbiological reporting. In those cases, if the patient is really doing well, you can actually go by the clinical response. But if the patient is not doing well and is sick, then it's better to go with the biofire results, right? Or even phenotypic DST results. Now, in this case, what we see is a Klebsiella pneumoniae is isolated or detected in the sputum biofire, right? And the copy load is 10 to the power 5. Now, in general, the load of 10 to the power 7 or more in biofire panels is considered to be significant, right? That is point number one. But again, it all depends on the clinical scenario. If you have a pneumonia case, if you have taken a good sample and nothing else is coming positive, then even at 10 to the power 5 or 10 to the power 6, you're supposed to consider it to be significant. Anyway, so this is showing Klebsiella pneumoniae. We thought that this is going to be significant because of the clinical presentation. And then we saw the molecular profile. So it says there's NDM detected and OXA48 detected. So what is going to be our treatment option? Now, since this is NDM, so we have to manage this as a carbapenem resistant infection. Now, even OXA48 confers carbapenem resistant. Now, for example, if NDM was not present and if it was only OXA48, then what we could have done is only given ceftazidime avibactam, right? But Since the NDM is detected, then ceftazidime avibactam alone is not going to be helpful. We need to combine it with aztreonam. So the treatment here is going to be ceftazidime avibactam with aztreonam in, in presence of NDM. If no NDM, only OXA48, you just give ceftazidime avibactam and not with aztreonam. Okay. And the next scenario is that none of the resistance genes are detected. It's still showing Klebsiella, and there's some virus. Then you just keep the patient on ceftriaxone. And if say this patient's Klebsiella was also not detected, and if it was just showing human metapneumovirus, then in case of community-acquired pneumonia, you could have stopped antibiotics. So that is how you should, use biofire results rather than, picking every organism to be important or, picking every mutation to be important. So it is always to be interpreted in clinical context. So I showed you two examples. One was with NDM. Then I talked about without NDM, just say only OXA48. And then in this scenario where you don't see any resistance mechanism. Now, coming to our next case, again, important, case scenario. 55-year-old female, known case of diabetes, hypertension, CKD, NASH-related CLD, admitted with looks like a peritonitis presentation. Ascitic fluid is showing neutrophilic leukocytosis, and the gram stain is showing gram-negative bacilli, and the culture is positive for Proteus mirabilis. Okay, and this is the sensitivity reported over here. Now, would anybody volunteer to point out what is, probably wrong in this sensitivity, if anybody could? So we have Proteus mirabilis. This is what the lab has reported. Now, is there something wrong, or maybe it's all perfect and you can discharge this patient on oral antibiotics once she's doing better? Okay, so the problem over here is the lab has reported minocycline, tigecycline for Proteus mirabilis. Now, this brings us to the concept of intrinsic drug resistance. So I'll not go into each and every organism. I'm just going to highlight Proteus, where you see it is resistant to tetracyclines and tigecycline. So in this case, you cannot actually use minocycline, tigecycline, even if the lab has reported. The lab would usually not report it. This is just a hypothetical situation. So in this case, what you can actually do is you can either treat with carbapenems if the patient is sick initially, or you can just de-escalate to amoxiclav later and then discharge this patient on oral antibiotics. So this was in case of Proteus mirabilis. Some of the other intrinsic resistance I would like to highlight is polymyxin B for Burkholderia. So, usually non-fermenters, Acinetobacter, Burkholderia, Pseudomonas, Stenotrophomonas. So amongst this whole group, Burkholderia is usually colistin resistant, and it is sometimes, used even for identification of Burkholderia, the property of colistin resistance. And the last thing is this fosfomycin. So everything except for Pseudomonas is fosfomycin intrinsically resistant. Now, but fosfomycin is pretty tricky. Now, why is that? Because you will see that in this photo, you see that there is a zone of inhibition, but within that zone of inhibition, you are seeing some inner colonies. Now, that is why fosfomycin is rarely the treatment of choice for, severe infection as monotherapy. Now, for enterobacterials, fosfomycin can still be used. For UTIs, fosfomycin can still be used. But for Pseudomonas, CLSI does not define fosfomycin susceptibility, especially because of this inner colony phenomenon. Now, this inner colony phenomenon is not exclusive to Pseudomonas. It also happens in Enterobacteriaceae. But in Enterobacteriaceae, generally the success rates, if used for, cystitis or UTI, it's good. But for Pseudomonas, you should never use fosfomycin, even if it is reported sensitive by the lab, as monotherapy. You might use it as a combination with other treatments, but not as monotherapy for Pseudomonas. Now, next, again, this is something important from maybe your MCQ perspective, where they might just ask you about quinprestin, dalfopristin. Now, E. faecalis versus E. faecium. Now, generally, E. faecium is the bad guy. So, if you see a more resistant enterococcus, it is usually the Enterococcus faecium. But the exception is for quinpristin, dalfopristin. In this, E. faecium is sensitive, but E. faecalis is resistant. So, this is something just for the exams perspective, I would say. So, briefly talking about some of the antibiotic combinations you might have come across, I have come across, and I find it very difficult to navigate my way, past these antibiotics. Now, first of them is ceftriaxone sulbactam EDTA combination. Now, I would say that there is some data. There's a good randomized control trial that was published for ceftriaxone sulbactam EDTA, but that was to evaluate it as a carbapenem sparing therapy. So it was used in comparison to meropenem. So it was evaluated against meropenem. But the common practice these days is it is not being used as a carbapenem sparing agent, but it is being used in a carbapenem resistant settings. So that is where there is no data to support its use. So we have to be a little careful while we are prescribing ceftriaxone sulbactam EDTA. We should probably gather more information on its usage. Next is pharopenem. Now this is one of the biggest headaches because everybody thinks that it's an oral carbapenem. It is not. It is not a carbapenem. It is a penem class of antibiotic. It has sulfur atom in its core and not a carbon atom. The problem is people are using it left, right, and center. So patient has a carbapenem sensitive strain. It's given 5 days of meropenem and is suddenly discharged on oral pharopenem. And then, of course, after 2 weeks, the patient has a relapse of symptoms and comes back in a sicker condition with carbapenem resistant infection this time. So be very, very careful. I would strongly suggest not to use pharopenem. Same is true for levonortifloxacin. Again, there's a lot of anecdotal evidence. People say it's working, it's working. But as a scientific person, unless you see good studies, you don't see trials or even good quality observational studies, I would just say that steer clear of drugs like pharopenem and levonortifloxacin in your clinical practice. Uh, that is the most scientific advice that I can give to you. Next, novel combinations again that we come across is things like meropenem sulbactam, cefepime tazobactam, amikacin combinations. I mean, there are all kinds of combinations that are available in the market. Again, unless there is data to support its usage, if the lab cannot perform susceptibility testing on these antibiotics, please do not use these combinations. Stick to standard treatment guidelines. The outcomes are much better and more predictable when you follow these standard guidelines in most of the cases. Again, this is a table that you can memorize, just mark it for later. What I want to highlight is sulbactam durlobactam, which I already mentioned, which is probably going to be very beneficial for Acinetobacter infections once it becomes available. And again, cefiderocol, if it becomes available in India, it will probably be a good option for a lot of infections. But again, not going into details, the cefiderocol data is not like 100%. It does not 100% denotes success. There are some shortcomings with the data on cefiderocol, but in general, it is considered to be active against most of the resistant mechanisms in organisms of our interest. Okay, so this is something just try to remember. Just follow the color codings also when you're reading this graph. Last but not the least, our case scenario number 7, 65-year-old male admitted to the ICU, acute exacerbation COPD, on steroid piptazo azithromycin, has improvement but again starts deteriorating, and the CVC insertion site is erythematous and tender on examination. And of note, MRS's screen at admission was positive, and the carbapenem resistant screen was negative at admission. And eventually, the blood culture grows Staph aureus, methicillin resistant Staph aureus. I mean, dealing with Staph aureus is a class in itself. So I'll just leave it at risk factors for MRSA. If there's colonization, previous history of infection, recent hospitalization, Community-acquired necrotizing pneumonia, always think of Staph aureus. Post-viral pneumonia, think of Staph aureus, think of fungal infections, history of IV drug users, contact sports, etc. So if you have risk factors for Staph aureus, it depends now if you're thinking of Staph aureus from the community or from the hospital. What are the possible treatment choices that you have? Uh, these are the treatment options that you have available. Now, the first few ones are mostly for hospital-acquired MRSA infections, and the last four ones are usually for community-acquired MRSA infections. But again, very important to note that Staph aureus is something that does not hide anywhere. So you send blood cultures. If blood cultures are negative, then most likely there is no Staph aureus, right? So it's not like you start ticoplanin for a suspected staph infection, you send blood cultures and the blood culture is negative and you still say, no, this could still be staph, so I'll give ticoplanin forever. That's not the right approach. So staph is something that would easily grow on blood cultures. What is important is that you send the right volume of blood cultures. So what we suggest, what everybody suggests is at least two sets. What are two sets? It's 10 ml is one set. So 20 ml is one set. So when we are talking of two sets, we mean 40 ml of blood. It might seem, like, oh my God, 40 ml of blood has been taken out. The patient might be very concerned. Patient's family might be very concerned that 40 ml blood is taken out. But you have to counsel them, because a positive blood culture not only makes things easier, it also makes things cost effective, right? You can de-escalate on a lot of antibiotics and a lot of treatment once you have a positive blood culture. So initially it might look that four blood cultures are like a lot of blood volume, a lot of cost, but believe me, it's half the price of even a 1 day course of any antibiotic in these days, right? So never shy away from sending the right volume of blood cultures. Higher the volume, higher are the chances of you being able to detect the organism. So with this, I'll just end. I think we have done quite a bit, 1 hour. And to summarize, there's nothing new. Like managing drug-resistant infections is becoming more and more challenging. I mean, with all the case scenarios, I could not even cover all the case scenarios that we see on a daily basis. But this is how we usually deal with most cases on a daily basis. Limited treatment options for XDRO cases, it's becoming more and more difficult. Responsible usage. I hope all the 50 participants start using. I'm sure they were using antibiotics very responsibly, and now they will be even more responsible. Plus, ask people around you to be more responsible and start broad, de-escalate later if the patient is sick and has risk factors for drug resistance. Be wary of intrinsic resistance. So sometimes non-standardized labs may report a lot of antibiotics that are not consistent with the susceptibility profile in general. So be very careful when you're looking at results from smaller labs when you don't know if it's really reliable. So you have to be wary of intrinsic resistance in organisms, and then consider the site of infection while choosing antibiotics. Like I explained in that case scenario where if it was VAP, what I would do, if there was intra-abdominal infection, what I would do, etc. And then avoid using unapproved drugs, a combination for the examples that I gave. So I think that should be all. It's a lot of information. I mean, we can keep talking about all the possible case scenarios, but I think this should be helpful for you in general. Thank you.